So the ZUMA-11 clinical trial is a trial that is sponsored by Kite Gilead, which combines their CAR T cell therapy, known as axicabtagene ciloleucel, with a 4-1BB stimulating antibody called utomilumab. And the rationale behind this trial is that 4-1BB is active on T cells, and particularly on CAR T cells. And if you add this antibody to the CAR T cells around the same time you're infusing the CAR T cells, you may be able to change the properties of the CAR T cells so that they function a little better. They may expand to a higher amount, and they may release their cytokines in a way that leads to a little bit less toxicity. Now, this study is still in the phase 1 development, so trying to find a dose for the utomilumab to combine with CAR T cell therapy. But interestingly, as this trial was first developed, there were 3 dose levels, and now we were able to go to the FDA and ask for an amendment for an even higher dose level of the utomilumab. And so currently we're working out some of the treatment in a higher dose level of utomilumab. We're very excited that this will be able to lead to better outcomes in CAR T. But again, we're still in the phase 1 phase of that. Moving on to the question around CAR T cell resistance, I think that a lot of information has come out lately about patients who are on the ZUMA-1 clinical trial or the Juliet clinical trial, or in standard of care practice about what are the characteristics that lead to CAR T cell resistance. And I think that these fall into several categories. So first off, we're starting to learn that the CAR T cell product is very important. And it seems like if you have more undifferentiated cells and fewer of the effector cells in the CAR T cell product at the time that you infuse it into the patient, then you get better expansion and better overall characteristics of the CAR T cells. However, more recently, and in some of the work that we're doing, both in collaboration with some consortia and on our own patients here at Moffitt, what we found is that there are actual patient-specific factors that can affect whether or not a patient will respond to CAR T cell therapy. And so these include things like a patient's performance status. Are they able to be up and around and to really be out of bed? And things like their tumor burden are very important. And in some of the translational work that we've done, we think that this is related to some of the inflammation that is released by the tumor. We think that the tumor causes a systemic immune dysregulation with high levels of cytokines and high levels of suppressive myeloid cells that then go on to make the patient feel sick, and they decrease their patient performance status, but also to prevent the CAR T cell from really expanding to the levels that they need to expand to. And then once they get into the tumor, to become exhausted through some of the tumor inflammation that's going on there. In addition to this, we think that you need a certain number of CAR T cells to overcome the tumor burden that's there. We call this the effector-to-target ratio. So if you have a large tumor, you need more effectors or more CAR T cells. And so we think that these larger tumors are associated with more inflammation, so you kind of get a double whammy. You have these large tumors that need more expansion, but can't get enough CAR T cell expansion because the CAR T cells are being impaired by the inflammation that is generated from the tumor. So we are hoping that we can find ways to overcome these inflammatory capacities or to potentially debulk the tumor prior to CAR T cell therapy, and that may lead to a better outcome.